towards the end of the meeting, around 3:45 or so. If you are interested in providing public testimony, please make sure that you sign up so we know how many folks we have. Okay? Let me start and see if there are any task force members on the phone. Any task force members on the phone? All right. Task force members aren't needed, right? Ash is making sure. Okay. So can you do that now, or we should do it?
Are now in interactive talk mode.
Hi there, is there a task force member on the phone? Okay, if you are a task force member on the phone, and if for some reason you're unable to let us know you're on the phone, please email Ash or Lisa so we can make sure we enable you to...
Are now in listen-only mode.
Okay, so let's go around the room, and this will be just a little tricky, but this is probably the hardest it'll be. I'll go to Helen. I got it. So if you could introduce yourself and your organization.
Helen Turner with the Oregon State Board of Nursing. I'm a clinical nurse specialist with prescriptive privilege.
Lisa Whitmore. I'm an NP at OHSU. I do inpatient adult pain management.
I'm Kim Maurer. I am at OHSU. I'm the medical director of the Comprehensive Pain Program.
I'm Minnie Doka. I'm at the VA Portland Healthcare System. I'm the director of the Pain Center.
Ariana Schott. I'm representing Legacy Health. I'm the lead for pain management across palliative systems.
Hi, Joe Taylor. I'm the medical director of the Oregon Medical Board. I'm Joe Schnabel, the executive director of the Oregon Board of Pharmacy.
I'm Eve Klein. I'm the medical director of CODA Treatment Centers and also the president of the Oregon Society of Addiction Medicine.
Lisa Louie, Oregon Health Authority Quality Improvement Director.
I'm Jonathan Robbins. I'm a professor of internal medicine and internal medicine at OHSU.
Hello, I'm Michelle Marica. I'm a peer support specialist for chronic pain and a person living with chronic pain. I'm Laura Heasacker. I'm a licensed clinical social worker. I'm here on behalf of Care Oregon, Jackson Care Connect, and Synergy Health Consulting. Katrina Buse. I'm a pain psychologist at OHSU and the Comprehensive Pain Center.
Hi, I'm Kim Swanson. I'm a licensed clinical psychologist with a specialty in behavioral medicine and health psychology, and I'm the director of behavioral health at Mosaic Medical.
Hi, I'm Paul Coelho. I'm the medical director of the Salem Health Pain Clinic. My name is Mark Cantor. I'm the pharmacy director of All Care Health.
My name is BJ Lynch, and I'm currently a medical director at a Sante health system down in Southern Oregon, but I wanted to be transparent and let everyone know that I'm transitioning to a position with a telemedicine company to provide medication treatment in Boulder Care in Oregon.
I'm Sabina Qureshi. I'm a family medicine and preventive medicine medical director at Columbia Pacific PCS.
I'm David Labby, Health Strategy Advisor for Health Share of Oregon.
Katrina. Is it on? Yeah? No, maybe not. Okay.
Katrina Hedberg, and I'm the State Health Officer and State Epidemiologist at the Public Health Division here at the Oregon Health Authority.
Great. Thank you, everybody. So we're asked, Lisa, do we know if we have any task force members on the phone? Okay. Okay. So I'm going to let you go. Dana is going to give us an update on HERC and a couple of other things.
Great. Thanks, everybody, and thanks for being here again. This is our third task force meeting together. One announcement as it relates to membership of the task force. It was our intention from the beginning to have more representatives with lived experience on this task force. And so we've decided to reopen the application process to do so. We'd intended to do it Monday and announce that, and it's just been a really busy week. So it is going to be posted no later than Monday. I hope, and I will send an announcement out to all of you And I certainly hope that you can help circulate the news. We'll be trying to do that in our own ways as well, and hope that we can bring on an additional member with lived experience around chronic pain or opioid tapering between now and the next meeting. So stay tuned on that. The second thing I wanted to just share is an update about the decisions made by the Health Evidence Review Commission. There were lots of questions by the task force before on that topic, and I know a lot of people following what the decisions were made. Just to remind you, the Health Evidence Review Commission makes coverage decisions regarding the Oregon Health Plan benefits. And over the course of the last year plus, they have been considering proposals about covering newly treatments for 5 chronic pain conditions, including information coming forward from a chronic pain task force. This is really the final decision. Those coverage decisions are made on those big coverage decisions are made twice a year, and the final decision point for the next biennium was last week. And there are, I think, three things I just wanted to share with you. So regarding those 5 chronic pain conditions, the Health Evidence Review Commission decided not to move those to coverage, and specifically that was related to the limited evidence around effectiveness of the treatments that they were looking at with regards to treatments for those conditions. So those conditions and their treatments have been uncovered, and they are not changing that based on the decision for now. There is definitely known further evidence coming forward, and they're really intent on keeping an outlook on any new evidence that might help them provide more coverage for effective treatments moving forward. The second piece that I wanted to share that they made a decision on, as you know, opioid tapering has been part of coverage guidance that was put into place back in 2016 as it relates to back and neck pain conditions. And from some of the information you'll have here today that we're going to talk about, forthcoming evidence, lots of public input and expert input over the last year. There's been a lot of concerns around the requirements around tapering for people with back and neck pain who were on opioids already. And so the HRC at their meeting last week decided to remove that requirement of tapering for people who have back and neck conditions who are already on chronic opioids. They also thirdly decided that they're going to further reopen those back and neck pain guidelines again by this winter to look more holistically with a further focus on opioids. So this decision in the interim was made because of forthcoming information about the concerns and risks about tapering being a requirement from a coverage standpoint. And so they made that decision now, but we'll do further discussion around the back and neck pain guidelines by this winter in line with new evidence we know will be published. So those were the 3 major things I wanted to report back from the HRC. I would just also say I had the opportunity to tell them about this task force that was underway, and that you're very strongly interested in bringing your work forward once you have put forth your guidelines to help inform their work moving forward. Any questions about the HRC? Okay, and then I just wanted to highlight, we're going to get into the meat of our conversation here in a minute. We've previously brought forward a set of resources that exist that we've been referring to as kind of foundational information, and we added 2 pieces of information from those resource lists since our last meeting. One of them was directly in your packet, and that's the FDA statement that came out in April, and it just speaks quite a bit around just risks and considerations around opioids and specifically references tapering. So I thought that was really important. This was definitely something that the HRC was looking at as they made their decision, and I think it's really important that we have this at the forefront and can discuss it in our dialogue. And then also, I couldn't give you the direct article from the New England Journal of Medicine, but I provided you with a link. One of the co-authors is one of the members, Dr. Chow. I don't think he's joined us today, of this task force, but it was a perspective article from some of the authors of the CDC guidelines around opioids and their perspective on the intent of those guidelines. So I wanted to make sure that was part of our resource and dialogue as you prefer today. So I just wanted to highlight those before we move into conversation. Okay.
All right. So we're going to jump right in. Let me show you what's in your packet, and we'll be using that for our discussion today. The first few pages, after the agenda, you have an article, but then you have the notes from a summary of our last meeting. Then if you go to page 12, we're going to start with the outline, and then we're going to talk about the principles. So I'm just tweaking this a little bit. But if you look at page 12, that's the outline. And what I want to, of what we think the task force will be producing. So has everybody got it? It says 12 of 23 on the bottom right-hand corner. And what we did, so we took your comments from last time, and as well as from staff's additional review. People getting there? Is it not numbered?
My cut off on.
Oh, I'm sorry.
When okay. The outline of the guidelines, the draft outline. It's in the staple.
Yeah. So let me walk you through. I'm just going to, because you know, I have page numbers. So first page is the agenda. Second, third, fourth, fifth, page 6 is an article. Then the next thing you should have are the notes from April 12th, and that is 1, 2, 3 pages, about 4 pages. And then the next thing you should have is something that says Oregon Opioid Taper Guidelines Task Force Prescribing Guidelines Draft Outline. Is everybody there? Okay, I apologize. Number that page 12. That will help.
It's not the page 12 at the back of it.
Yeah, okay, I don't, mine came out nice and clean. I'm sorry that yours didn't, but we'll figure it out. Because we're going to now walk through this page by page, essentially, okay? So does everybody see it? Eve, do you see it? Yeah. Okay, so here's what we did on the outline. We added, you can see a section on patient-centered approach, so that will be in the guidelines. And then you'll see that there's a couple of comments, and this came from staff review of resources, that under taper plans, we added a general approach and taper plan examples. We also, further down, added a section on managing withdrawal, and then we added a section based on your input on when to refer. So this is our working outline, right? And it might still change, but we wanted to share with you the tweaks we made. Anything on this folks want to add? Any questions? All right. Let's go to the next page. And that says working document. And I'm going to explain how we sort of structured this. This is what we're going to be populating through the discussion, and that we started last time. If you look, I'm just going to take a moment to explain how we've done it. So we're going to be, if you look at sort of the first and second page, and I'm going to talk about those in a moment, the things that are in regular font are what we've discussed and what we've sort of, and we're all going to come back to all of this, but what we've quote unquote, we've reviewed it, we've made decisions about it, we've put it in the working document, okay? So then if you look at the, later under definitions, those are in grayscale print, and that's because we've already discussed those things. Okay, that's what the grayscale print is. We've discussed it. So as we discuss and make decisions, things will turn to grayscale. Does that make sense? Okay, we're trying to save paper, but and sort of make this easy for folks. Then, if you look at where we start patient assessment evaluation, we did talk about that last time a fair bit. We did not make any decisions, so it's not grayscale. And we have some ideas about how we might move forward in that section. And then we have a section on when to consider tapering that I hope we can discuss today, as well as a section on approach to tapering I hope we can discuss today. And towards the back of your packet, there are some examples from the VA DOD on clinical practice guidelines for opioid therapy. We'll be looking at this, but we wanted to share some of these resources with you. Those are sort of the last 5 pages, something from the OPG, the Oregon Pain Guidance group. So that's what's in your packet. Any questions before we now dive into the content? All right. go back to the principles. So what I want to do with you all now here is we did make some final changes to the principles. It's on the first page of the working document. And then we're going to then I'll just point out what we did on the definition. So we changed a couple of things here based on your comments. We put data-driven instead of medically realistic. We wanted to double-check that with you because we added evidence-based. I think we had group agreement on that. So before, I want to see if anybody has any final things on the principles, and then I'm going to, again, we can always come back to this in a couple of months if we need to, but for now, I want to see if anybody has any comments, and if not, I want to see if I get a thumbs up, thumbs down, thumbs sideways. So any final, almost final comments on the principles? Oh, please, go ahead, Jonathan.
Patient safety? Harm reduction.
So,
Wrapping patient safety into harm reduction?
I think that was probably part of it, yeah. Does that feel okay to you? Patient-centered, I think folks felt like that might have been covered. I mean, it doesn't, so that patient-centeredness, and I think harm reduction, focus on pain science, I think that there was a sense that some of that got to it. But no, Helen?
I think harm reduction and patient safety are two different concepts, and that we should call out patient safety.
Okay. I'm getting some nodding heads. Yep. Okay. This is why we look at them another time. All right. So that patient safety will add patient safety. Great. Okay. Anything else? All right. So for now, can I get a thumbs up, thumbs down, thumbs sideways? Okay. Great. And again, we don't have anybody on the phone as far as I know. All right. Then we're not going to, I just wanted to show, so we walked through the definitions last time, and so you can see we sort of took from the resources, we had the CBC, the OPG, the VA, Washington, the DSM-5, and we've made decisions about what we wanted to include in the definition. So you can see that on that first and second page. I'm not going to go over it in detail. And we added something. You all asked that we add a specific definition on medical abandonment, and we added that as well, because there seemed to be some confusion in the community or in the room about what we were talking about when we talked about medical abandonment. Okay? David, absolutely. Could you grab the mic right next to Sakina? Thank you.
It does reference doctor-patient relationship. It should be provided. A doctor.
Yes.
Just saying.
Okay.
Provider-patient
It
relationship.
should say provider. Thank you. Good. Yep. Great.
Thank you.
Provider-patient relationship. Thank you. Okay. All right. So now what we're going to do is I want to talk a little bit about patient assessment and evaluation and where we landed last time. And we have a thought about moving forward, but we wanted to check it with you. So we spent a fair amount of time on patient assessment and evaluation. We got a lot of input. We didn't we didn't finalize it. And so one of the things we talked a fair bit about was, should we have some sort of algorithm or visual, or I don't know if it would be a conclusion tree, but sort of if this, then this, then this, then this, and we talked about doing that. And one idea we had was, rather than try to do that as a huge group, whether it made sense to ask for a couple of volunteers who would take a shot at that and we would make sure that they had all the, what you have the meeting notes, but we're working with staff, obviously, to draft something like that and come back to the next meeting with something to share to the group. So that's an idea. I wanted to see what people think. I'm getting a few nodding heads. If people think, let a small group take what we talked about last time, come up with some kind of algorithm or visual on patient assessment and evaluation, bring it back for discussion. Yeah? Does anybody have any concerns about that approach? And then I'm going to ask for volunteers, so get ready. Any concerns with that approach? Okay. Who would like to volunteer to work on a small group with staff on coming up with some visual before the next, or algorithm, whatever it is, before the next meeting?
I don't have a mic. I think we have a lot of people, it's not a concern, it's just a comment that it would be ideal if we had one person.
Yes, right.
I'm volunteering. She's available.
Katrina, are you taking up the volunteers? Or Kim, are you volunteering?
I can. I'm joking. I'm happy to participate if Katrina doesn't like me directing her to do so.
So Kim's volunteered to help. Others? Jonathan, go ahead.
There are online, and it's for different organizations, there's a number of existing.
Yeah, right.
Yes. Yep. Some of them are actually on the So it may be, you could sort of do like a tapering research and then find the algorithms that look suitable and not recreate it necessarily.
I think that would be part of it, absolutely.
And just to clarify, so we're going to be moving from this evaluation assessment piece in a second after we have a plan, and then we're going to be. Sorry, I'm trying to find my. We're going to be moving into.
When to consider tapering.
So I just want to make it clear what we're talking about. So this is the what kind of evaluation assessment has to be made, and then the next section is going to be when do you consider tapering, and then approaches to tapering. And I know, Dr. Dogra, you had offered that the VA has some evaluation assessment tools that you could bring the content, some of the subject matter for it to help inform that conversation. You shared some of that with us. So we thought that would be a useful thing to lead into this small group. And anything else you all have or know about out there, we would love to add that in. But it was really this, and that we captured in the meeting summary from us, but this idea about an algorithm and some of the key parts of that algorithm that you wanted to make sure were in there. So I think this would be, a phone call or two, trying to get to a document that you all would feel comfortable with us bringing forward.
So that I was just going to say, this is not like a multi-hour commitment. This is probably a couple of hours in the next month. Anybody? Great. Helen and Kim. So I have two Kims and a Helen. And Laura?
No, I'm not.
He got the mic and I'm asking for volunteers, and that is going to happen.
Tim has covered on this.
Okay.
I don't know if it's on, but it doesn't matter.
It does. It actually does matter. Make sure it should say look red. There you go.
There. I sent Lisa a PEG video, and I noticed like a lot of the PEG tools, the 3 questions, a nice PEG interview, and so I would just encourage the group to take a look at that. The group that formed, it was very well done.
Great.
I second that. That's consistent with VA as well.
No.
So, I think standardizing the use of the PEG with every follow-up visit is something really helpful.
Great. Good. Good. Please, Minnie. Do you have a...
So I tried to fix sound issues, and we made new sound issues. So
just on the PEG point, VA just came up with a new pain rating scale, which is called the DVPRS, Department of DoD and Veterans Pain Rating Scale. And it actually has faces, it has numbers, it has colors, to red. But every number has a descriptor attached to it. And it kind of talks about the function. If you're a 10, you're curled up in a ball. Pain is all that matters. Nothing else matters. And then it talks about how it's affecting your daily activities. So if you're a number greater than 4, that means you're thinking about pain all the time and you're not really participating in your activities of daily living. I think I've shared that with some folks at OHSU as well. And if you guys are interested, I can send you copies of that. It is a validated scale. And more and more VA systems are starting to use it. The only criticism for that scale was because it's a small card and the font is really tiny. So for our veterans, it's kind of hard to read, like, what is it saying? So in our inpatient settings, in our wards, we actually have bigger copies, and we're actually using it because the Joint Commission came up with pain assessment standards, which came into play last year, January. We have a Joint Commission visit soon. So we incorporated that in our pain assessment, which is done by nurses and other providers as well, to have that scale so we can demonstrate some sort of function. And some of the functional elements in the inpatient setting, especially post-op, is
kind of along those lines, but I always worry when I see words like advanced stage.
Tell me where you are.
Under medical comorbidities. One, I don't know that advanced stage is a medical comorbidity, but I think it's also very...
That's more than others.
Yeah, but the problem is, if I look at my patients on opioids, most of them are elderly and they take 1 or 2 hydrocodone a day, and I'm never going to taper them. They function. So looking at that, because we saw this on the Oregon Pain Management Commission as things heated up. A lot of medical organizations just blanketly said everybody needs to be off opioids, and without any kind of risk-benefit assessment. And I think, you may also say somebody who's 90, if they get some benefit, even if it likely shortens their life, why not? So, yeah.
I just remember that we cited CA and our advanced stage and your advanced stage is completely different.
No, I understand that, but... Right, but advanced stage is a tricky kind of thing. It's vague. I guess anything in here that's vague language that's really subject to interpretation, I would try to remove.
You suggest taking, I'm looking for, are you looking to suggesting taking out advanced stage?
Yeah.
What about medical frailty?
Oh, okay, so hold on. So let's hold on a sec. So I did want to check before we finish. Yeah. I'm pretty loud, but So we're gonna hold that advanced age piece for a moment. Do we feel like we came to resolution about, and see, without my notes, I'm going to be useless, but that we came to resolution about the other piece, what David was talking about? Katrina, do you have a resolution on that? I'm not sure about resolution, but I was going to comment on what Jonathan was saying. In the other guidelines, and I've said this before, let's not reinvent the wheel. Those do talk about doing an assessment not only of how much pain scale, et cetera, although we didn't come up with the pain scale, but type of pain, whether it's responsive or not. So I do like the idea of cross-referencing, because that should have happened not only for the acute pain, but for chronic pain, et cetera. Although I did hear that even though, and what's difficult here is that if we do evidence-based or science, and people are talking about some of these types of pain, like fibromyalgia, et cetera, might not be responsive, but if it's working for the patient, then is that evidence-based or is that patient-centered? So occasionally these principles might be a little bit in conflict. My only point was that we shouldn't reinvent what it is we are talking about when we say assessment of pain, whether it's a degree of pain or type of pain or whatever. That needs to be done, and we should reference where we've already been with our other guidelines.
I agree with everything people have said. I think this says consider tapering doesn't mean mandatory taper. And so when I have a patient who has clinically, when I assess them and I realize that their main pain condition is maybe it's trauma, maybe it's fibromyalgia, and they're on opioids, but they're doing well, I do consider tapering them, because then I remove the long-term side effects of opioids, which could be more subtle than falls. Could be osteoporosis, hypogonadism, development of central sleep disorders. So if you feel like it's picking on people, but I would say clinically I do consider tapering. I say, listen, you might be able to do the same or even better than you are now off of opioids, and then I would sort of do the MI around that.
Okay, now we're going to go back to unless, did you have a comment on this piece, Laura? to do something on this piece because we're going to talk about the advanced age thing. Okay, so there's a suggestion. So there's a suggestion to take that out, and then folks definitely have.
And then the last year's overdoses were majority women over the age of 65. And so while psychological comorbidity tends to go down, medical frailty tends to go up. So calling it out in some way, because we confused that, and my last overdose was in an elderly person on 30 NED, so which is consistent, with what our ED sees. So age, while it works in our favor behaviorally, it works against us in terms of frailty and polypharmacy,
David, let's go with Jim and then David.
That way the benefits, and it may be just a brief check to see are they functioning well, is everything going well. You've considered it, but these are I think what we're really talking about here are the people that you consider more heavily. But I really do think that everybody should have a consideration because the evidence just isn't great that these things are beneficial for people, and there's a lot of evidence of harm. So certainly don't taper everybody, but at least consider it for everybody.
Go ahead, David.
Just building on that, I think the principle is that everybody on opioids should be repeatedly assessed for risk and benefit, right? And that what these bullets are common risks, right? The risks include, but are not, so we sort of say, well, here's common risk things, but this is not exclusive. We don't have to think of everything. But the principle, which I think you just well articulated, is you should always be the overall risk benefit to anyone on an opioid. So I think that just makes it simpler.
Let's go to Laura and Michelle. And I think we have hold on, we can use this. Okay, then let's use this one. It's skill building in some weird way to like have to go.
So I agree with what's been said, and I'm just thinking about that the first statement is, risk benefit, right, and then examples underneath. And some of the things that I was circling that were concerning to me were like severe, unmanageable adverse effects. If people are just thinking about if the drowsiness has to be severe and unmanageable before we're going to consider somebody with drowsiness for a taper. So that was my comment.
That was a very powerful comment.
That was that's such a subjective comment, right? Like define severe. What is severe versus what it is? Severe may be entirely different. Yeah.
That's what I was talking about. Very subjective.
There's going to be some.
Okay, one other comment that I was just thinking about as we were having this conversation is, does it make sense to call out something like problematic prescription opioid use as an example? It doesn't really get stated, but it's sort of spoken to around non-adherence to treatment plan or unsafe behavior. So I'm just thinking about that.
Thank you. Michelle. And then...
So I do agree with the severe part, that we should change severe, take it out, because it should be just any unmanaged symptom and side effects, but also we don't have any mention of hyperalgesia in here at all. And that is hyperalgesia that should be moved, towards the top of the list of unmanaged symptoms that never get looked at and never get talked about with patients.
Go ahead.
I agree with what everybody's saying. I like the idea of not considering advanced age to be a medical comorbidity. I wonder if instead of using the term medical comorbidity, that language could just be medical risk factors potentially. And then I'm thinking lung disease, sleep apnea, liver disease, renal disease, fall risk. All of those could be on a spectrum of severity from very mild, where it might not be a significant concern, to like quite severe and causing increased risk associated with opioid use. I think kind of this entire bullet point list of considering tapering when, they're just things to think about. And I don't want to try to be too specific around how severe it needs to be and when to, like everyone's saying, we should always think about it. These are just some what to think when we're thinking about it, what risk factors to consider. So maybe the recommendation is we always want to be considering risk versus benefit and reassessing the risk versus benefit. And when considering what those risks are, look at these factors, and it's all these bullets.
Yeah. Okay. So that you may have picked that. So let me just restate it to make sure I got it. And I'm going to go to Ruben and Joe. Okay. So what he suggested was taking David's earlier statement about there should be an assessment of risk versus benefit. Oh, sorry.
These conditions may actually put you at higher risk of overdose or substance abuse, but just understanding your audience, that whenever people see a bullet list, they're looking for, does my patient match that?
I think that's a great point. Okay, then we had Joe, and then Laura.
So the only number on the list is 90 MUD. And I have to say I like that, if the group can agree to that, because I've seen folks say, I'm stable and doing well on 240. Why would you want to reduce my dose? And so if there's anybody who has feelings about that 90, I think they should, whether it's too high or too low.
All right, so let's hold the number. We're going to come right back to that. I want to come back to that in one moment. Laura?
Sure. I was just going to say on the next page under treatment progress, the OPG recommendation says thorough and a systematic risk-benefit assessment reveals that. I think it's actually backwards. It should be risk outweighs benefit that you would consider a taper. So just offering it up as some language we could maybe use for that. But I think we have to switch that around.
Yep.
Okay. That's it.
I'm going to go to Helen right
Yeah. I think one thing that I would like to see added to this, though, or back into it, is when we're talking about advanced age, is the medical frailty, because we have patients who are medically frail who aren't old, and they are at higher risk. So if we're going to have verbiage, I would like to see that included.
So, okay, Paul.
I'd like to second Joe's. I like that 90 number.
Yep, we're going to do that right now.
Hospital because he was on opioids, antidepressants, anti-anxiety medications, all of these. And so that is why the VA is really looking at the mental health conditions. And, if you look at the risk tool that I sent out to Lisa, the mental health conditions carry a high risk on patients who are on opioids. So we've picked 50 or greater, and for people who will be participating to be providers for veterans, you will get a letter from us saying, this is what we do, but we're not saying you cannot prescribe greater than 50. You just have to say, we've done a risk assessment, patient is doing well, it's okay for them to be on 90, and we'll be okay with that. But you will get some sort of a notification if you're taking the veterans about what our guidelines are.
I want to comment on that because, we went down the pathway of different payers having different rules before. And I think that's really dangerous. While I agree that as low as reasonably possible, that's the safest. There's no safe dose. I think it's really the wrong pathway for Oregon to go to pick out different payers to have a double standard, personally.
So what's your
90.
Yes, Julie.
90.
Okay, E.
So specifically in this context, we're calling out this number, not saying everybody at this number or higher gets tapered. Just like lung disease, sleep apnea, liver disease. We're not saying everyone who has any of these things pull them off opioids. We're saying they're risk factors and that we should be aware of them, we should have a conversation about them, we should consider them. And so since that's how we're defining this list, I do agree that 50 needs to be the number because we know that there's increased risk of overdose that we start seeing as low as 50 milligrams a day. Not saying no one can be on 90, but I want people to be aware that just because we're between 50 and 90, that doesn't mean it's not a risk factor we need to think about.
Somebody over here have a... Oh, so many, go ahead.
I think that is the reason why we chose.
That's the reason I think we chose that number. And it's just making the physicians and whoever are prescribing to be aware that if it is beyond 50, then you have to do a risk assessment, and you just have to let us know that the patient's doing fine. And you're not being told that you have to not go above that dose or there's no mandate. It's just that we want to mitigate any risk that might be available present in that patient. It's just...
So let me go to Jonathan and then Paul.
I'll, I guess, channel Roger for a second, Roger Chow. So part of the point in the editorial in the New England Journal was that this 90 number has become kind of burned into, it was a try not to exceed 90, but a lot of payers, Medicare, has really said that this is sort of, if you're above 90, then you're in trouble. And there's been a lot of really heavy-handed, beyond the scope of the CDC guidelines in terms of getting people down to 90 or 50, that I think is, if you're at 95, that you're bad, and if you're 85, you're okay. And so there is, I agree with, actually, I think that if there was a number, it should be 50, because that's when you look at the data, when the odds ratio of overdose goes up. On the other hand, these numbers can be misinterpreted in clinical practice and by people that run systems, and that is really not patient-centered. So I'm kind of torn in between. Because this is what Roger's point. Now you always pay us, and we'll never give you above 90. But actually, that's not what it says at all.
So what about compromise that says 50 to 90, something like that? That range.
You have to do what everybody else.
So I think we need to go back to who are we writing this guideline for. I think that health systems will invariably try to interpret them in whatever suits their sort of je ne sais quoi. I think we should write the guidelines based on the evidence and what is the safest. And if we're all in agreement that 50 is where the risk now becomes exponential, I think we should aim for 50. But I also think we should call it out in the document that decisions regarding insurance and funding and the fiscal side of it should be based on clinical judgment between physician and patient, not based on a number.
Just to be clear, there is no inflection point.
Yeah. So hold on. So we're not. There might be a difference of opinion on this, but I think I'm going to come to David. What I hear us struggling with, and I think Arlen put it well, is the idea here is, and again, we're going to have some statements to clarify what this section is about. It's not about this is when you should taper. It is about folks should be reassessed on a regular basis, right? You should make sure that the benefits outweigh the risks. And here are some items to consider when you're considering risk, okay? And then we can have a statement somewhere, if this is what the group decides, we're not going to decide it this second, but we could have a statement somewhere that talks about the challenges, and we can use 50 to 90 here, or 50 for this example. We can have a statement somewhere that very explicitly talks about and lifts up this idea of patient-centeredness and not a hard and fast rule, and that this is a decision between the provider and the patient, and these are not meant to be dictatorial, because that is not how these decisions will be made between patient and provider. Something, it won't be that, but it'll be something to capture the spirit of the discussion. Does that make sense? Okay, David.
This is more of a question to Paul and others. So if there is no inflection point, we know that this goes up, right? So So maybe we just ought to state in the most distinct way we can what the risk profile looks like with increasing dose. So if the evidence suggests that, whatever that is, we just say what the evidence is. Because in fact, those which indicate high risk, is 50 the definition of high risk, or 50 the definition of starting to be high risk, right? It's really, so why don't we just say what the evidence is, so that people have in their brain that you've got to establish some way of saying what your definition of high risk is, and then let them decide. So I don't know if that's possible.
So Kim's going to tell us.
Well, I don't know, but I like that idea. I think we should say where the evidence is. I don't really believe, at least when I look at the literature, and I'm not an expert on it, there is really an inflection point, I agree. And so I think we should, because there's too many factors around opioid prescribing and the clientele and the environment they're in and the mood. So I would just show what the evidence is and then let the provider and patient kind of make a decision based off that.
Down to Joe. Can you do it?
So I think it's important to have a number. When you're thinking about, when you just say, any higher dose of opioids is dangerous, you're not telling people whether that's 240, 50. You do it with blood pressure, you do it with cholesterol, and neither of those are quite as deadly as an MD of 240.
Paul, and then I want to see what people think about David's idea on the evidence. This is what the evidence says now.
So, I want to hone in on that. So, the Edlund article with Mark Sullivan in it, he looks at odds ratio of opioid use disorder based on dose. And it's 450,000 patients, so it's big. And with a dose of 0 to 36, the odds ratio of developing opioid use disorder was 15-fold higher than somebody that wasn't on opioids. Something like 36 to 90, it's 30-fold higher. And above 120, it's 123-fold higher. So it just goes up and up and up. And I think we ought to reference the Edlund article.
Would that work for folks?
That's looking at risk of opioid use disorder, but we also need to look at risk of overdose.
But it almost always precedes the overdose. The abuse disorder or the
So can I get the mic because I have a suggestion?
Yes.
Go ahead.
Steve, can you repeat that?
Yeah.
Okay. So my thought is I'd like to, if we're going to decide that we're putting the evidence directly in this, I would like the evidence to represent not only evidence of developing a opioid use disorder, but also evidence of developing an overdose, because in different populations, those don't always go together.
Okay. Do you know if there's that evidence out there? Yeah. Okay. So here's what I'm going to ask for. The Edlund article, we can get that, I assume. Other articles that have the evidence, could you guys either give us the references or send them to us, either today or email them to us? Because here's what I'm going to sort of summarize, because I think we're done with this section. But I want to make sure. Oh, I have one actually outstanding issue, and then Joe has something. I have one issue. Hold on 1 second. The issue I have was Michelle's point about hyperalgesia and whether we were going to include that as a potential risk. Is it okay? Okay. I wanted to make sure people were cool with that.
I would include that under the unmanageable symptoms.
Unmanageable adverse effects. Yeah. Good.
It's
okay.
not severe.
Yeah, we're going to take out the word severe. Absolutely. Joe.
So you mentioned assessment on a regular basis for these elements, and it's not really written that way.
Right. Or it's assessment on, I think the language was around assessment of the risk and benefits, and these were a list of risks that you, and we're going to use this.
But at the beginning, it might say something about assessing these things on a regular basis.
Yep. Continuous assessment.
And then one other thing, I'd like to give a shout out to other drugs other than benzodiazepines, other sedating medications. like antihistamines or other sedative hypnotics like zolpidem, things that aren't benzodiazepine. So just generally other sedating medications.
Other sedating medications. Got it.
Yeah.
Polypharmacy. Are you going there? Hold on. Oh, no, Jonathan does have the graph there that I refer to a lot with the 50 and 90 inflection points. But I wanted to add also that the adverse side effects, you have a really good list. It's more comprehensive than this. I don't think everybody really knows a lot of the side effects, and I think that that's also important for providers to know. It's more than just drowsiness, constipation, and cognitive impairment. Jonathan, would you send us your adverse side effects list?
I've got it right here. The other point is that we do give patients who are over 50 morphine equivalent to naloxone kit. That's really clearly specified in the CDC guidelines. So and I haven't done this yet, my guess is that if you look in the reference section of that, that's where you're going to find all the articles about the dose relationship between the dose and overdose risk, because the 50 didn't come out of a hat. It's an evidence-based thing.
Okay.
Not evidence-based. We just made it up.
You got to do something. I'm sorry.
This kind of all started with the group health article from 2010, the CONCERT study that showed that there was a rising risk of overdose with that was followed up by the VA study. That's the ones that showed about 8 to 10-fold above 100. It's weird that 90 got used to be the number, and I think it's the dosing convenience because morphine comes in 30s and not 6. But there's a lot of articles that show that.
Okay.
I don't think that's really in dispute that higher doses are more dangerous.
Okay, Katrina. Yeah, I was going to make just a general comment. It seems to me that part of what we're doing here is we're trying to figure out what's the science, what's the evidence base, and again, I would agree, there's not a single inflection point, and then how it gets implemented, and that's where the problem is. I mean, that's how come, people have, if you will, incorrectly implemented the chronic disease guidelines and been assuming that it's for other things, or chronic pain guidelines, which resulted in Roger Chow. So I think that's part of, at least when we're talking about how these get implemented within health systems, somehow in this we need to be clear that part of the purpose of these guidelines, and I've said these are guidelines, that doesn't mean they should be in statute or, but nonetheless, how they get implemented within health systems, that's the problem. That's where the 90, because, if they're doing a computer that's going to have a trigger at a certain point, it's going to trigger at a 50 or a 90 or 120 or whatever it is. It isn't going to say, in this patient maybe or whatever. So I think we need to consider that, especially when we do, because I'm trying to remember there is a section for what health systems should do, or when we're considering, it really has to be that some of these shouldn't necessarily be that there is a trigger point at 50 and thou shalt not. That's what's gotten us in trouble a lot before. Okay, so I'm going to summarize where we are. We're going to take a 5-minute break. I know that was important. I'm going to summarize where we are. We're going to take a 5-minute break, and then we're going to come back and we're going to talk about approach to tapering. Okay, but let me summarize what I think I heard, and I might not capture everything, but I'll try. So I know we have lots of folks taking notes, but the bottom line is we're going to revise this and bring it back to you. The key pieces that I have in terms of revision is we're going to make sure we add a statement about continuous assessment to make sure the benefits outweigh the risk. These are going to be examples of risk. We are going to, and we're going to be our language will be really crisp and clear in articulating that. We're going to take out, and I don't know if there are other adjectives like this, but I know we're going to take out severe in the second bullet. We're going to add hyperalgesia. I can't even say it there. In terms of the dosage piece, I think what we decided is that we're going to say 50 to 90, but we're also going to have a statement somewhere close by, I don't know exactly where it goes, around the most up-to-date evidence, and this is what it says, and just so that we have that. We're going to, instead of saying medical comorbidities, we're going to say medical risk factors. We're going to keep advanced age. We're going to add medical frailty. Under the next bullet there, we're going to also add polypharmacy to that. And then on that last bullet, we're going to rework some language around worsening of mental health comorbidities due to opioid use, something like that there. So those are some of the big changes. I'm going to guess that I have some things in my notes, Dana and Lisa and others, that we'll double check to make sure we got anything. But is there anything really significant that I completely missed? Okay, so we're going to take a 5-minute break, just because this is hard work, and we'll come back and we're going to be talking about approach to tapering. Thank you.
It's a little bit different because it's not just multidisciplinary. It's the clinic support as well as the organization support. So your clinic needs to be capable of supporting individual practice. That means, Paul, you've done a lot of work with your MA. So it's a different game, and you can't just sort of take this on as a rogue player.
The way I see it, like in a regular primary care office that doesn't have every single interdisciplinary human there to help, the biggest help is integrated behavioral health. But if your organization doesn't support that or fund that, then how do you have that support? So still on the big headings, and you can see them in the outline. Anything else you want to add? So I'm going to go to Jonathan because he's got the mic, and then I'm going to pass you this mic.
So one of the big things is the role of medication-assisted therapy is a broad heading better to say recognizing or diagnosing complex persistent opioid dependence or opioid use disorder, and then under that heading is the role of MAT, because it's really important during papers for providers to be able to screen, to sort of recognize what's complex persistent dependence, what that means, and what's an opioid use disorder, and how to manage those.
That's great.
Yeah, just be the third person to kind of call out buprenorphine in some way. It needs a bigger space. And
Pardon? You're going to go under complex.
Well, I'm worried about that term, but at some point, there are a lot of experts that are saying in Oregon that success is a transition to sublingual buprenorphine as much as a taper. Somehow there ought to be some parity that we recognize that a transition to buprenorphine is equivalent to a taper. I mean, we should be pushing that forward somehow, that language that taper to 90 or 50 to 90 or a transition to sublingual buprenorphine is equivalent.
Okay, great. Can you pass that down here, please?
No.
Sure, I just want to... When we're framing the language around the value of a transition to buprenorphine, I think it's important to keep that in the context of treating an opioid use disorder. So there's a lot to put into this. And so they're not literally equivalent in that if a person doesn't have an opioid use disorder, we wouldn't be giving them the choices of, hey, want buprenorphine versus taper. But if we uncover an opioid use disorder or concerns of one or potential one, then we definitely want to strongly prefer MAT over taper. Okay, so just so I'm clear what we're talking about, I think we're talking about renaming this one category that says role of medication-assisted treatment and making it broader. And a lot of the groups that we've been involved in, there's a talk about dropping complex persistent opioid dependence, which is because it doesn't exist anywhere like as a diagnosis, but really just using opioid dependency and then being able to, maybe there's a way we can sort of use that broad heading to sort of span that gray in between all of it.
Great. Good, Michelle, please.
I do want to say something about that. Just because it's not a diagnosis, neither is central sensitization. That's not a diagnosis either. So it's hard to compare apples to oranges. Do you want to take that outside yourself? No.
I'm just relaying that there's been a lot of discussion around using the term complex persistent opioid dependence and people that have made that term up saying that they want to not use it anymore. That's the only point I'm...
And we, at our last meeting, decided not to have that in our set of definitions. But so we will, but I think the point is having that MAT section be a broader section that isn't just MAT, also making sure we're calling out buprenorphine, please.
So I just want to also throw out there that I will frequently use buprenorphine as a safer alternative choice for patients who are on chronic opiates, as I'm sure many other people in this room do. I think we need to call out the fact that that medication is not just used for MAT, and that, in fact, it's a safer alternative to opiates for some patients or a better choice for specific patient populations. I'm not sure where that belongs in here. I'm just kind of throwing it out there because there's definitely a push to get more primary care hospitalists comfortable with using buprenorphine as a medication, not necessarily for MAT purposes, but also for MAT purposes.
And the diagnosis that I code for is opioid dependence because I'm not starting naive patients on buprenorphine. It's really only for patients who are on moderate to high dose opioids who then rotate, kind of like Paul rotates people. So it's not. So it's sort of like it's opioid use disorder light, either mild opioid use disorder or it's DSM-4 definition of opioid use disorder, which would be dependent.
But that's really, really complicated because it's not. If a patient doesn't actually have that diagnosis and we put them on buprenorphine, the coverage issues that come up and then also placement issues that come up. So, for example, there's a patient I had placed on buprenorphine, very low dose, 2 milligrams BID for chronic pain, who was not doing well with standard opiates for a whole slew of reasons. I had a skilled nursing facility refuse to take him for 41 days because they would not take a patient who was on MAT, even though I had repeatedly said, this is not MAT, this is for chronic pain. I think this is a very tricky insurance issue, so I don't know if anyone can speak to the insurance aspect of that in this group, but I think we need to figure out that piece of it.
Mark, maybe you can answer the question I was going to pose to the group. I just want to, maybe I can add my question and see if you can add it. This is not my area of expertise, but I'm hearing a lot of this nuance around, off-label use, when is it used, and I want to make sure we're talking about, what evidence do we have out there about this that are informing the guidelines, that we can be really clear and succinct about what we're putting in the state-level guideline. So that's just what I want to call it. And what's emerging practice, what do we have evidence for, et cetera, and make sure all of that is really clear.
Yeah, so I can speak. I can speak to how the pharmacy side of things are covered, and so forth. What we look for is the opioid dependence because not all pain conditions are funded when we're looking at Oregon Health Plan patients. So that really would, in that case, make sure that a patient would have access to the medication as opposed to where they just had a non-covered pain diagnosis. And a lot of it does go back to their FDA-approved labeled indication. So that's what we are looking for coverage on the pharmacy side. I don't know that it's standardized across the state.
Okay. Josephine, do you have something to add?
I also just want to clarify that a nursing home or whatever saying they won't take somebody because they are on MAT, that is not an insurance issue. That is a
organizational policy, potentially discriminatory issue. So that's not a coverage issue. For the record.
Just to follow that up, there's a lot of confusion and concern about can prescribers who don't have a NEXT license prescribe buprenorphine. So I think to this point, we really need to put in an entire sort of buprenorphine 101 for dummies that is intended for everyone who is confused about these things. It's not that people are actually dumb about it. It's just, I think it needs to be spelled out so explicitly.
Well, let me just say,
their agreement that we need to add that. No. So I'm saying, okay, so I'm going to come to Kim in a second. But I just want to be clear, too, about where we are. We're looking at these on the outline, these big topics, and some folks, we need to add something in buprenorphine. And so I'm going to just say something right now. We're actually not going to talk about the details of the buprenorphine piece because there's so much more here to check. But that's going to be, Katrina, we're going to go down that road, not right now, because I want to make sure we're all on the same page about the outline. Katrina.
I was just going to say, in state-sponsored guidelines, I don't know that we can recommend any off-label use or any of that. I might ask my pharmacy or other, but that isn't to say that there might be other groups, subcommittees who wanted to look at potential and that could, if you will, have something, considerations, etc. But I'm just saying, even, a call out, if it's off-label, I probably does not belong in state guidelines.
okay.
Yeah, I was just calling the question. This is not Eric. I was looking for people, experts, to be able to speak to that, not saying it was per se.
Okay, and mine was the question mark.
So here's what we're going to do. On the outline, if you look at the outline, the suggestion is to make that MAT section broader, and an MAT would be under a broader section about opioid use disorder. We're going to, TBD, have call out something on buprenorphine. Kim, I'm going to come to you in 1 second. There's also the question raised about wanting a statement around team-based care somewhere that it's, I don't know exactly where that goes, but I think that makes some sense. Then to Safina's point about the organization and how it supports this work, you may call it out in individual sections as well as at the end. Kim.
I have a lot of voice, but it's probably not.
Right, yeah, so I guess right. So looking for comments on the outline, the big heading.
I'm just recalling the discussion around buprenorphine last.
You need to broach this subject with patients over and over and over again and normalize it and set expectations. So I think
Looking at that.
Yeah, I think adopting that and wording it however we can word it.
I have it in front of me. If anyone's interested, I could just say what it stands for. So it's broaching the subject, risk-benefit calculator, addiction happens, velocity matters, and so does validation, other strategies for coping with pain. I don't know. I guess I'm not quite sure how, just like approach to tapering is one of our categories Bravo, or do we just use those and begin to make some headings out of those things?
I like the thing. You like
the second thing?
Yeah.
Yeah. I think it makes more sense. Some of them might not fit in this, I don't know.
I think the things that were appealing to different people from the different subcategories fit into taking Bravo and separating Bravo out into categories and then taking those things that appeal to different people and applying them to the appropriate heading. Does that make sense? Because there were different things that people liked from the different categories. And I think one of the things that I would definitely include as part of the I like
engagement as sort of the descriptor because we do need to engage with our patients in going down this pathway with us. One of the things that I want to call out here is something I really want to see included in this that is under the Washington one, had to do with the patient education about safekeeping. I think one of the biggest challenges during a taper is how to do this safely where meds are actually being dispensed appropriately, talking about things like lock boxes or having a friend holding the meds or who's going to be responsible for co-partnering with you on doing it appropriately and safely. I think that's something that we need to talk more about because I don't think it's actually called out enough.
David, go ahead.
Well, in keeping with our other approaches, we basically, what we're doing here is we're laying out the principle that you need to think about how you're going to engage the patient. And there's a bunch of tools that you have to have a patient-centered approach, and that we could refer, as we have in other places, to all of these tools, the Bravo, whatever. But what we want out of the guideline is we want an organization, a clinic, a provider to think about, how am I going to do this? And we don't have to tell, we don't need the cookbook, but we need them to think about that on the path that we're on. This is an important stop to be able to, that you need to define. So it's good enough, and this is probably what we need, but we need to just call out the space. And so I don't know engagement could be patient-centered engagement, maybe I would use patient-centered in it because I think that's, you're not going anywhere. I mean, there's lots of ways to engage people. Some of them are patient-centered and others. Yeah, I mean, all of those things, but something like that people think about the space, and we give them enough so they have some tools to start with. Because, again, there will be new tools.
That makes sense to folks that approach. Good. Okay. I think we can look just for a couple more minutes. We'll drop that, the ideas,
patient-centered engagement, and then call out some specific tools. But we'll look at that as that's sort of the big principle, and then again keeping it broad, but then maybe referring to some tools and something like similar to what we did with the earlier section about this, includes but is not limited to sort of following considerations. Okay. So then the next section is on setting goals and defining success. Comments on that? I think this is the last one we'll probably get to today. Go ahead.
So as we think about patient-centered things like shared decision-making, that really fits into this category for me. So I don't know if we need to join the two categories or if we're talking about something different in the category before, but shared decision-making is really that process for me.
That's a lot of nodding heads on that. Okay. I like the CDC. And the CDC one is more aligned as a principle, kind of. Go ahead, Steve. There's a mic there. Thank you.
When I'm looking at the CDC description for setting goals and defining success, that, to my mind, is speaking to setting goals and defining success for chronic opioid therapy. And then, so I love it, and I'm not sure where it goes. So we need to define what our goal is with setting goals. Are we setting goals for the taper or for what opioids are? Okay. All right. So then, okay. I wonder if we can modify, because I like the principles of the CDC, but I don't think we can just copy and paste that in because they're talking about when you start opioid therapy.
Good. Okay, so whether it's the taper or starting opioid, I think the goal is the same, which is safe, lowest possible dose, best quality of life and function. That's kind of the good result I'm getting from that. So out that before starting opiate therapy, I would say during opiate therapy and tapering. Okay. Michelle.
I have one more comment. We have a really good, common beliefs and perspectives, informational kind of graphic here. And I think it would be really important to put some of these kind of key notes into that section because it's not necessarily about life goals. It's about the paper and some of these things about, really what your beliefs are with your patient and what their beliefs are during tapering is super important. So we have a source link and
share that.
Yeah, Laura will. Yeah, I shared it with Lisa, Louie. I sent her both of these article links and the summary.
I have 5 files I can along from the group. Just a couple more seconds.
Okay. All right. All right. So we will. I'm going to wrap this up because we do have some public comment and then some logistical business. We will on these 2 sections. We'll look at combining them because and let's just see how that goes. To BJ's point, I saw a lot of nodding heads. We'll look at which of the sort of resources here pull out, and to be really clear that we're focused on tapering, during tapering, and we'll look at the documents that you guys sent Lisa, and we'll bring something back to you. Okay? And we're going to stop there. And so when we come back together, and we'll talk about next meeting times in a few minutes, we'll have done some work on those previous 2 sections, and I think we'll be starting with paper plans. Okay. I was going to do the public comment right there, Ash. Is that what you're thinking? Okay. We have, as far as I know, 3 pieces of public comment. We have written public comment that I'm going to distribute. I'm just going to dispel confusion. This was sent to us as public comment. It actually is addressed to the HERC. But it was sent to us as public comment for all of you. We were asked to give it to all of you. So we're giving you the written public comment that we got. I have 2 audience members who've asked to give public comment, and I just want to, because we haven't had public comment, I want to just share how we're going to do this. We're going to allot 3 minutes per person for public comment. I'll let you know when you have 60 seconds or so, and there's only 2 of you. We'll call you to the table one at a time. If you have any handouts, let us know, and we can make sure they get to the task force members. So when you come up, we have a microphone there for you, and I would just ask you to state your name as well as any potential conflicts of interest that you have. And we'll take it from there. So the first person I have is Tim Harless. I invite Mr. Harless to come on up to the table right here. Thank you. And let's make sure that microphone is on.
I turned it on. Oh, it's on.
It's on, great. Okay. Mr. Harless, could you please introduce yourself? Thank you.
Yes, my name is Tim Harless. I'm a chronic pain patient. I've been for many years. I'm a refugee from the VA system. I'm also an advocate for the American Chronic Pain Association. Somebody you probably never heard of, but we're collaborating with the National Pain Strategy with HHS, and this whole thing started. But people don't really know that about us. They just think nonprofit American Chronic Pain Association, Anyway, just to you know that we've been involved in this pain shenanigans for a long time, and we've had our input into it. And I'm really encouraged by what I've been hearing here today. People who really sound like they care for the patient. But ultimately is the goal here, to take care of the patient. When I first was hearing about these task force, et cetera, it seemed as though everybody was concentrating on taking opiates away from everybody. And the CDC and FDA just recently came out, and I'm sure that Beth Darnell, his hand out, from the head of Stanford, yeah. He wrote an article, the head of CDC wrote an article, FDA just wrote an article, all about how forced tapering sucks. You know, psychologically and physiologically, you are really upsetting the status quo with the patient. And the patient is the one who's been suffering out there. And I will take that. I have to say this, I've said it before, because it's not being mentioned enough. There are people who are being driven to suicide. They are dead already. I'm dealing with people who are suicidal, who are not dead. Thank the Lord. But these are people who are chronic pain patients who have lost their medication. Their quality of life went instantly in the toilet. Their life sucked. And there was no help. Now, the reason I say what I just said is because I read a book not long ago and made me really understand. You have to be impeccable with your words because your words really have meaning. And in this particular instance, I cannot think of anything much more important than how you impact somebody's life, somebody's quality of life. Will they be able to work, take care of their family, stay in their home instead of hitting the street because they can't afford life anymore? Why? Because they can't work, because they're in pain. Why? Because nobody will help them. Now,
Mr. Harris, you could just wrap it up.
Okay, I'll wrap it up. I was getting real to it. Thank you very much.
Thank you.
But wrapping it up, it's real simple. Caring for others, other than yourself. Think about those who cannot be here and speak for themselves. That's why I'm here. Okay. And what we do does impact people immensely. Thank you very much. Have a great day. Okay?
Thank you so much.
Oh, and that's Mr. King.
Thank you. Thank you. The next public comment, thank you, is Anne-Marie Hartman.
I didn't think I'd be doing this today, but here I am. Thank you. My name's Anne-Marie Hartman. I'm an oncology nurse and also the relative of a 30-year-old chronic pain patient. I wanted to speak to patient-centeredness and the patient perspective to pain, to chronic pain. I live in pain all day long. Sometimes it's lower, sometimes it's higher. The only immediate control I have over the pain is through medication. I live in fear all day long. Fear that my provider will decide to cut my dose at my next visit. Fear that the pharmacist will decide to deny or delay giving me my pills, even though I took my last pill 4 to 6 hours ago. And I have a legitimate prescription, but pharmacists are allowed to do that. Have done that. Fear that my pain will spike and I'll never, ever be able to bring it down again due to the law. Fear that every medical person I see says drug addict behind my back, even though I'm trying to get off using. So to that perspective, I would like to speak to patient education. There are many patients who try to come off the opioids. They realize full well what it's doing to their life. This particular person was on 700 morphine equivalents per day a year ago. It's now down to 60. There's been a lot of pain along the way and a lot of depression and anxiety. When we speak to the patient education piece, I think that especially speaking around tapering, the word you want to use is empowerment. You want to use patient empowerment. Patients need to be involved in this discussion. They need to feel like they have some autonomy in this particular discussion. They need to be told by their providers, we're going to try going down by 10 milligrams per week. And you try it for 2 weeks. If it doesn't work, we'll go back up and let you hang out at that higher dose for another 2 weeks. Because that gives them some control, and they have no control anymore in this current environment over their pain. I think that's pretty all I wanted to say. So I really appreciate your time. And I do appreciate the atmosphere of moving away from the taper or die kind of situation that we're facing right now. I'm not sure why it went that far, but it was inappropriate for many of the patients who have chronic pain. Completely unnecessary and caused a lot of harm. Thank you.
Thank you so much. Okay. Thank you. Couple of logistics. Thanks to all of you for giving the last few hours to this important work. Our next meeting, and I'm looking to Ash and Lisa to make sure I have this right, is June 14th from 9 to 11:30. We are thinking about extending that for half an hour just because we still have a lot of work to do. And so would folks be able to do 9 to 12 on the 14th? Does that take, I'm getting mostly nods. Okay. So we will extend that. And then, Ashley, so what are the July and August meetings? We just wanted to make sure that you guys have them on your calendar